of making you aware about various guidelines and consensus group consensus reports, we will be discussing about international deep endometriosis analysis group consensus. We all know endometriosis is a complex disease and is characterized by presence of ectopic endometrial glands outside the uterine cavity. There are many theories about how these endometrial glands get implanted outside the uterine cavity. One is the retrograde efflux of these endometrial cells during menstruation into the peritoneum, and it is said that that is the reason it occurs in most of the dependent parts of the pelvis. Other theory is the peritoneal cells and endometrial cells, they have a common embryological origin, and then that is also results in having these ectopic endometrial glands outside the uterus. So very common gynecological conditions resulting in life alerting morbidity. It affects quite a number of females in reproductive age group. The exact prevalence is difficult because all patients have variable clinical manifestations. Patients with symptoms, they have a higher prevalence, and around 50% of those are associated with infertility, and most of them have a chronic pelvic pain. The common symptoms include dyspareunia, dysmenorrhea, infertility, and chronic pelvic pain. The symptoms may vary as per the location of the deep infiltrating endometriosis. Surgery is considered to be reference standard for diagnosis of these cases, but there are certain limitations for surgery because it cannot estimate the exact degree of the disease. Then sometimes it's difficult to assess the lesion depth on laparoscopy as such, and the lesions may be obscured while for the surgical field of view. So again, endometriosis involves multiple locations, has good definite spectrum of disease, and there is a varied ultrasound appearance and manifestations. In ovaries, it appears as endometrioma. In uterus, it appears as adenomyosis. The superficial endometriosis is where the nodules or the plaques are along the peritoneum, and there is no organ or retroperitoneal invasion. The DIE, or the deep infiltrating endometriosis, is more than 5 mm invasion into the peritoneum, or invasion into the organ or into the retroperitoneum. And other sites are the pelvic adhesions, pouch of Douglas obliteration, fixed ovaries called kissing ovaries, and hydrosalpinx or hematosalpinx. And ultrasound is the often initial imaging modality for evaluation of endometriosis. What are the advantages of ultrasound? We know we can do a dynamic assessment that acts as an extension of physical examination. We are doing real-time study, and we can do certain maneuvers to look for the site specific tenderness, to look for provocative maneuvers, again to assess the organ mobility, in between organs how is the mobility, and definitely ultrasound is quite readily accessible and inexpensive. But is our routine pelvic ultrasound is adequate? No, because our protocols are focused on uterus and ovaries only. At the most we see additional whether there is free fluid or no. Sometimes we try to see whether tubes are dilated or not. Then operator dependency is again a hindrance in ultrasound, and therefore because of these two there is a decreased sensitivity. So what we need is a dedicated protocol. We need to incorporate the advantages of unique features of ultrasound that can give us an accurate mapping of the disease, and can plan the treatment strategies. Treatment strategies could be medical therapy or surgical therapy. Medical therapy using hormone to avoid surgery, or surgical planning to need the level of complexity, the need of surgery, and to finally to achieve the complete restriction of the disease, because that is the ultimate treatment for the patient. So this idea group was formed with following goals. Goals to improve the detection and assessment of endometriosis, especially DIE. Standardized result reporting, including the terminology of location and uniform measurement practices, thereby improving the clinical care and definitely research. So they have given us a consensus statement and given an examination protocol. This has majorly 4 components. Component 1 is what we do routinely, is evaluation of uterus and evaluation of ovaries. So as we do a routine evaluation of ovaries, we need to add the sonographic signs of adenomyosis or presence of endometrioma into it, because adenomyosis and endometriosis are quite closely associated, and whenever you see adenomyosis, patient tend to have severe symptoms and higher stage of the disease. And it is said that the DIE patients, almost 50%, will have adenomyosis, and these patients will present with menorrhagia and dysmenorrhea. And the uterine adenomyosis is ectopic endometrial glands and stroma within the myometrium. There can be cyst or there may not be cyst, and therefore there is adjacent smooth muscle hyperplasia. How we see here is a pseudo widening of endometrium with indistinct margins. In the second image we can see multiple myometrial cysts, and we can see some hyperechoic nodules, striations into the area around the endometrium. Some more features in adenomyosis are abnormal myometrial echogenicity, like it could be hypo, iso or hyperechoic. It can be a heterogeneous myometrium. The heterogeneity as seen in this case could be focal, could be diffuse. There can be myometrial cysts as we have seen in the slide earlier, and some echogenic nodules or linear striations, then those are also reported. The pseudo widening and poor definition of endometrium we have just seen. Next part of the component 1 is evaluation of ovary. The features of endometrioma include unilocular cyst that may show homogeneous low level echoes. There will not be solid component, no internal vascularity as seen in the image, and it has a perceptible good wall with bright reflectivity. The endometrioma mind well is a marker of severity, and the symptoms in the patients with having endometrium in the ovary, they present with pelvic pain, dysmenorrhea, dyspareunia, and infertility. Certain other features of endometrioma, they can occur due to bleeding in these ectopic endometrial glands, and once the bleeding occurs due to blood products, there can be formation of fibrous capsule, and these are quite common. Around in 50% cases they are bilateral, and then they can produce some atypical ultrasound features, like seen here is a fat fluid level, and sometimes you see nodule or some papillary projection within. And during pregnancy, the decidualization may occur that may mimic malignancy with solid vascular components, and we should remember that. The fallopian tubes can get involved due to adhesions, and they can form the hydrosalpinx. This is in transverse and this is in longitudinal section. And hemorrhage within, they may result in hematosalpinx, and that it is seen as some level, and we can see the fine internal echoes that are seen in the fallopian tube. So which areas can have diffuse infiltrating endometriosis? Bladder, ureter, all areas around the uterus, anteriorly or posteriorly, bowel, uterosacral ligaments, vagina, retrovaginal septum. All of these can have deep infiltrating endometriosis, and that we will see in next few slides. So component 2 is search for these nodules. So you need to search anterior to the uterus and posterior to the uterus, and in these two compartments we can be searched. As madam had shown in her demonstration, you need to keep the probe anteriorly in the anterior vaginal fornix to see the bladder and other structures, and need to keep the probe posteriorly to see the posterior compartment, including the rectum, rectosigmoid, sigmoid, and the pouch of Douglas. The anterior compartment, for the visualization of anterior compartment, the bladder should have some amount of urine to see the walls of the bladder. Then you can see the trigone area. Then the trigone contains the orifices of urethra and ureters, and that is within the 3 centimeters of urethral opening. Then you can see the base of the bladder, that is anterior to vagina and the cervix, and this is the extraperitoneal part of the bladder. Then dome of the bladder is the posterior and the superior part of the bladder, and this is quite commonly involved, and this is an intra-abdominal structure. And then we need to evaluate the ureters from orifice to maximum proximal visible extent. The posterior compartment includes a bowel and a retrovaginal area. The bowel includes lower anterior rectum, that is below the level of peritoneal reflection. This area is not seen in laparoscopy and we can try to see on a transvaginal ultrasound. The upper anterior rectum, then the rectosigmoid, that is at the level of up to the level of uterine fundus, the rectosigmoid, and below distal to that is the anterior segment, that is above the level of uterine fundus. And the retrovaginal area includes the vagina, the rectovaginal septum, and the posterior vaginal fornix. So that's the fornix, that is the rectovaginal septum. So how these nodules appear? Generally, the ultrasound features of these nodules, they appear either round or linear. They can have smooth or irregular borders, and mostly they are avascular as seen here, or can have some slight vascularity. The group consensus says you need to measure the nodules if seen in all three planes and report accordingly. And we need to use standardized terminology including location, shape and size of the nodules. These nodules are seen in around 15 to 30% of cases and typically involve the fibromuscular structures. The uterosacral ligament are quite commonly involved, then followed by bowel, vagina and the bladder. So for bladder, as we have seen, the red part showing that is the dome of the bladder, it's quite commonly involved. And out of all cases of urinary system endometriosis, bladder involvement is seen in almost 85% of the cases. And these patients, because of urinary involvement, they have urinary complaints like frequency, urgency, dysuria or hematuria. The bowel involvement is due to invasion of the muscularis propria layer of the bowel wall, and that induces a smooth muscle hyperplasia and there causes fibrosis. This is critical for surgical planning, and this is the common sites are anterior rectum and rectosigmoid junction. It is frequently multiple bowel involvement, and we should not have a satisfaction of search, and we should go for visualization of all the possible structures. And being a bowel being involved here, the symptoms will be GI like diarrhea, rectal pain or rectal bleeding. The ultrasound features they include, like seen here, is a nodule that can be smooth or round, or can have a taper tail like this, or can have spikes also. So they appear as hypoechoic nodules. There may be hyperechoic foci as seen here, and the margins may be most of them are well defined but can be blurred in certain extent. The rectovaginal area is difficult to evaluate and need practice, as the statement mentions. It reflects a severe degree of disease and quite often associated with already disease present at some other location in the abdomen. The symptoms are dysmenorrhea, dyspareunia and postcoital bleeding. The rectovaginal septum, the only involvement of only septum is rare and is always associated with involvement somewhere else. Then the vagina, as seen here, that can be involved. So also the rectum can be involved, or both can be involved. The fornix, vaginal fornix, we can have deposition of endometrium. And sometimes the lesion extend to rectum beneath the peritoneal reflection, posterior to the bladder, posterior to the uterus, in between uterus and the rectum, and that can give a hourglass appearance. The uterosacral ligaments, we know they extend from the posterolateral portion of the cervix to they encircle the rectum and reach into sacral vertebrae. And the torus uterinus is the junction of these two, right and left uterosacral ligaments, just posterior to the cervix. Normally they appear as hyperechoic, but endometriosis presents makes it appear as hypoechoic with nodular or linear thickening, and it is a common location involved in almost 1/4 to half of the patients of endometriosis, and patient has dyspareunia. Next component is a sliding sign assessment. This is the assessment of mobility of structures, and we need to do certain maneuvers to demonstrate the normal sliding of structures with each other, and this is done in such plane with real-time assessment and a cine recording. So we will show you some demo of this, and for anteverted uterus, the probe is pushed into the posterior lip of the cervix or the fornix, and then somebody else that pushes the fundus down. So once you do that, you can see the movement. Okay, as you see here, the uterine fundus is showing there is movement in between the uterine fundus and the bowel here, and there is movement of the posterior myometrium or the uterus with the rectum. So then the bowel, anterior bowel, should slide relative to the uterus here, and the rectum should show movement with the posterior part of the uterus. So this is in an anteverted uterus, and in the retroverted uterus, again the pressure is applied transabdominally, and probe is pushed into the fornix, so that we see some movement. It becomes difficult to demonstrate this sliding, but with practice you can achieve that. One more sliding is between the bladder and the uterus. We'll show some videos that we have recorded for you, and that can be also elicited. Then here the positive sliding sign is considered normal. Whenever you see there is sliding, that is normal, that is positive, it is said. So once again you can see this posterior cervix that slides to the anterior rectum here, and the fundus, again this is showing movement with relation to the bladder. The negative sliding sign, whenever you see that there is no great movement in between the structures, that is a negative sliding sign, and it predicts pouch of Douglas obliteration. And then if both components are negative, the POD is considered obliterated, and this has accuracy, very high accuracy of 93 to 97%. So this you can see here that these uterus and the rectum, they are moving together, they are not moving separately, and again this endometrium in the ovary, that is again attached in the cul-de-sac rather. So the endovaginal ultrasound enables us a real-time assessment of the sliding sign. We have seen that POD obliteration is associated with significant increased risk of bowel involvement also. So we need to find whether there are nodules along the rectum to sigmoid, and it is quite critical to surgical planning, and it reflects the presence of non-specific pelvic adhesions. The last step is detection of ultrasound soft markers. It's quite easy, but it increases the diagnostic value. The superficial, this indicates superficial endometriosis and also adhesions. There are tenderness guided ultrasound. We can just put the probe into the vagina at various locations and ask the patient if she is experiencing pain, and pay dedicated attention to the site of pain. This will increase the sensitivity and the specificity of detection. The localization of fluid, adhesions, that also can be seen and considered as soft tissue markers. One more soft tissue marker is the ovary mobility assessment. Whether the ovary is freely mobile or fixed, you have to apply pressure between the uterus and ovary to see whether they separate from each other. So the movement that indicates that there is no involvement of the ovary or the peritoneum. Then some limitations of transvaginal ultrasound are definitely there. The technical limitations include patient factors, limited field of view, and this is location dependent, so sometimes you may not be able to see properly. Definitely requires training, education and time. And assessment of fundus, you need 2 operators, but still ultrasound is very good, transvaginal ultrasound is very good example, very good modality to assess these lesions. For example, this is the ovary and this is the nodule as seen here, and when you do dynamic they are not moving, they are not separable and in fixed position. Then another case, we can see both ovaries, they are posterior to the uterus and they are adherent owing to pelvic adhesions. This is the case of bilateral endometrioma. Then in the anterior compartment, you can see this involvement of the bladder, the base and the dome, they are involved, and that is projecting inside the bladder lumen. So we need to develop habit of looking at the structures where we can expect the location of endometriosis. In the posterior compartment, patient with irregular bleeding, you can see that there is nodular thickening of the muscular propria of the rectal wall, and there is no vascularity as such. The lesion is elongated, there is a tail appearance as we have seen in earlier description. This is intraovarian endometrioma with some fluid level, small fluid level and a nodule there. And in additional imaging, you can see a small nodule just behind the cervix, that is the uterosacral ligament, both ligaments coming together at torus uterinus. So what is the TVS protocol for endometriosis? 1. Do a routine evaluation of uterus and adnexa. Look for a configuration of the uterus, whether there is adenomyosis. In ovaries, locate them, number and size of the endometriomas if you find them. In adnexa, look for the hydrosulfings or hematosulfings. Then do a dedicated search of anterior and posterior compartment for the DIE, that is deep infiltrating endometriosis, and then do the assessment of the sliding sign for the vesicouterine and the rectouterine pouch obliteration, and then finally the sonographic soft markers like ovarian mobility, localization of fluid strands, and etc. So to conclude, TVS is an excellent tool for evaluation of endometriosis. We need to make ourselves aware how to look for it, where to look for it, and what to look for. Once we start doing dedicatedly and systematically, we find various manifestations of endometriosis, including the deposits, by transvaginal ultrasound. Thank you.